So my talk is going to be fairly brief, and I was asked to talk about tests during management of patients with brain cancers. And I struggle as I might, I couldn't really think of too many tests that we do, except for imaging. So most of my talk will be around that. In general, what we try and do with, there are two types of brain cancers in general. Patients either get primary brain cancer, Michael talked about that. In other words, the cancer starts in the brain and stays in the brain. Or patients can get other cancers that travel to the brain, in which case we call it secondary brain cancers. And the management is a bit different depending on what we think is going on. So with primary brain cancer, the standard of care is surgery to try and cut it out if possible, and that's not always technically possible, followed by radiation, plus chemotherapy. And the chemotherapy bit is like an add-on and is relatively new over the last few years because it extends survival. And so that's the standard of care, particularly for patients with glioblastoma multiforme, of which brain cancer, that's the most common proportion of brain cancer, is about 75%. There are variations depending on the subtype of brain cancer. So tests related to management often rely on imaging, which means scans prior to surgery and then following surgery, usually within a day or two following surgery, to see the extent of the resection by the surgeon, but also to make sure there's no obvious complications like bleeding in the brain. And then patients discharged, 4, 5, 6, 7 days after surgery. The remainder of the tests are related on to what type of treatment that they get. So for patients that have radiation, they often have minimal tests and they just see the radiation oncologist on a regular basis. If patients get Temodal, the chemotherapy component, then we like to do regular blood tests as well. So they're fairly standard blood tests, full blood count, biochemistry and so on. Not particularly interesting. What is interesting really is the imaging, and I'll show you some examples in a little while. For secondary cancers to the brain, the principles are more or less the same. If possible, the surgeon usually tries to cut them out, but that may not be possible. There may be too many, or they may be in a position that is really not technically feasible. Radiation is also sometimes used, commonly used, whether or not the patient has had their secondary cancer resected. And chemotherapy is much less commonly used for metastatic brain cancer, simply because the chemotherapy drugs often don't cross the blood-brain barrier. So if you've got cancers in the brain, it's difficult to try and shrink it just with chemotherapy alone. But there may be certain circumstances where it is used. And then in that situation, for secondary cancers, patients also get tests related to their particular management, depending on whether they have radiation or don't have radiation, and whether they have chemotherapy or not. So, as I mentioned, glioblastoma makes the majority of brain cancers, but there are other subtypes. And the management also varies a bit depending on what subtype you have. You may or may not get radiation or chemotherapy at all, particularly if you've got low-grade gliomas. So this is the anatomy of the brain, and I like to remind myself that it's a complex organ. Sometimes I joke, I tell patients that it is possible to cure brain cancer if the surgeons were able to chop out the whole brain. And that would be the end of it, And I guess for some people it doesn't really alter their quality of life. But yes, it is technically possible to cure brain cancer just with surgery alone. Clearly there's a tension about how much you can cut out of the brain and what you need to remove if you've got a brain cancer. And the different functions of the lobes are very important. So the frontal lobe, the parietal lobe, the occipital lobe, the temporal lobe, and then the bits of the brain below that are also super important because they control things like breathing and circulation. So they all have possible complications depending on where your cancer is situated and also what happens to that cancer and whether it's irradiated or whether there's scarring in and around that that site of the brain. The most commonly used imaging nowadays is an MRI scan of the brain, and there are certain features which make the radiologist more suspicious that this is a primary brain cancer. And I'm not going to go through that. CT scans are also used. They're sort of falling by the wayside because the detail on CT scans are not so good as an MRI scan. But not every hospital has an MRI scan, and so you do with what you have. So this is an example of a CT scan of someone's brain, and you can see the dark spot on the left. It's really not very specific, and all it really alerts us to is that something's going on there. This happens to be a patient with a stroke in the left middle cerebral artery territory. You can diagnose brain tumours with a CT scan of the brain, and on the top left you can see an obvious sort of mass, probably in the parietal lobe. But the pictures aren't always very clear, so depending on the imaging that you get and whether there's contrast given or not, sometimes the tumour appears much more obvious, but can appear hidden. This is an MRI scanner, so you already know that. It's a very powerful magnet. And the difference between a CT and MRI is shown in this slide, where the brain is bisected, or quadrisected actually. So you can see with a CT scan, say on the bottom right-hand side, you get this sort of greyish appearance, whereas the MRI, you can see a little bit more detail. Likewise, in the upper right quadrant, you can see more detail on an MRI than you have on a CT scan. This is an MRI scan of a patient with a glioma, and no prizes for guessing where it's located. But we use MRI scans fairly routinely, but this is also controversial. Not all oncologists would follow up their patients with MRI scans, and there's an argument, particularly for patients with brain cancer, who have a high likelihood of tumour recurrence, but who might be well. And the argument runs that if patients are well and they're working or living a normal life, why concern them with an MRI scan result that may herald the tumour recurrence? Because in that situation, you may or may not be able to do anything about the tumour recurrence, and so then patients live with a degree of anxiety and poorer quality of life because of the fact that they know what the results of the MRI scan is. So there's an argument to do MRI scans, and there's an argument not to do MRI scans. I happen to do MRI scans fairly routinely. It's typically every 3 or 4 months, but that will depend on the centre that you go to and the neurosurgeon and the radiation oncologist that you see as well. The reason I do them is because sometimes you can see some subtle changes which may or may not mean that the cancer has recurred. So you can see 2 MRI scans here, and this actually shows that the tumour has recurred in 2008, in August 2008. There's a bigger whitish area on the left, on the right-hand side of the screen, as you can see, compared to earlier in the year. So because of that growth and that abnormal enhancement, that makes us suspicious that this is a tumour. For a while ago, a few years ago, when Avastin became available, there was a concern that it actually didn't attack the cancer at all, and what it did was just to reduce the swelling around the cancer. Sometimes the edema around the cancer can show up as whitish appearance on the MRI scan, so you have a difficult time telling whether this is scar or recurrent tumour or edema or some other thing that's going on. So they did lots of MRI scans, and you can see that, for patients that did have Avastin, let's say the top 2 MRI scans, after a while the tumour appeared to shrink, and you could see that subsequently for other patients as well. So on the next 2 scans, you can see the tumour appears to have disappeared. Doesn't really disappear, but that's what it looks like on the MRI scan. And similarly for these two other patients as well. So there was a lot of excitement at the time that Avastin might be very useful in brain cancer. This is an example of a patient with a lot of edema around the tumour, and you can appreciate that it does hide the extent of the brain tumour. So you've got the brain tumour here, and the slightly whiter appearance surrounding it. And then when Avastin was given, most of the tumour appeared to have shrunk, but there was still some edema left as well. And you can't tell from that second MRI scan whether there's still residual cancer or whether there's part of it scarring or whether it's just all swelling in the brain. You can't really tell that detail. And then finally, occasionally, patients may also have a PET scan as well. That's not used so commonly, but I think potentially it could be a very useful examination. A PET scan is radioactive glucose, which is injected into the circulation and goes to areas of cancer, which then light up on the PET scan. So it's a dynamic kind of scan. It shows active areas of cancer. This isn't a picture of patients with brain tumours, but a neurological testing of PET scan to show that different areas of the brain light up depending on what people are doing at the time, walking, seeing, hearing, thinking and remembering, confirming that different areas of the brain are responsible for different activities. But that's the kind of thing that the PET scan might be able to give information about. And I think that's about all I have to talk about.
Great. Do I have some questions for Paul? If I can get out. Yep, one at the back there.
Good afternoon. I was just wondering, I know some surgeons don't like using PET scans or reading PET scans to their patients, and I was just wondering why. I know they read their MRIs, and I've had both, and then I've been to another neurosurgeon and they say, oh, I don't read PET scans, I don't believe in them. I was just wondering, is there a reason for that?
There are lots of reasons. Helen might have a good answer.
The problem with straight glucose PET scans is that they take up in areas of inflammation. So although we think preoperatively and pre-radiotherapy that if you've got a hot PET scan, it's tumour, once you've had radiotherapy, if there's any inflammatory response going on, it'll be hot as well. So we get all these false positive FDG PET scans. So having a hot PET scan post-RT can give everyone a very false message.
I was going to say that PET scans are done by the physicians, the doctors in nuclear medicine, and also known as unclear medicine, and there's a good reason for that.
Okay, do we have some more questions? I've got a question for you. Molecular testing, do you think we're ever going to get to the point, MGMT for example, where a patient comes to you, has their MGMT, it's unmethylated, they know that temozolomide has minimal benefit in that setting and they ask you for another treatment. What do you do?
That's probably going to be more and more of a common scenario, I think. At the moment, I don't have any answers. Chemotherapy does work in brain cancer, lots of different drugs, but very poorly because, as I mentioned, not a lot of them cross the blood-brain barrier. So it depends on how aggressively the patient want to be treated. I'd be more than happy to try, but it would be purely experimental. So if that wasn't an option, if patients weren't keen on that, then I would look for a clinical trial. But clinical trials are few and far between, and you have to fit certain criteria. So if patients didn't fit those criteria, then again they would miss out on that. Yep. So I don't have an easy answer.
Any other questions, Dan?
Professor, is there any one particular malignant brain cancer that is more susceptible to treatment than any other?
The oligodendrogliomas are classically meant to be more chemosensitive and radiation sensitive than the other types of primary brain cancer. And that probably is true based on the clinical trials and the evidence that we have. But it's all relative. Brain cancers in general are not so chemosensitive as, say, for example, ovarian cancer or breast cancer or some of the other cancers.